Well, good afternoon, Madhuri Jha. I'm so excited to host you today, all the way from New York, to speak with us about mental health access and care. And you're the owner of Thriving for All, which is really looking at mental health equity. You've got such a wealth of experience with your knowledge on research and epidemiology and clinical social work, and there's just so much there. So I'm really excited to dive in. Thank you for coming.
Thank you for having me. Excited to be here.
Yeah, so first of all, this is your life's work.
hmm
Why did you decide to dedicate so much of your time to this uh, topic?
Yeah, it's interesting because culturally, mental health is extremely stigmatized, and so I had a moment a couple years ago where I was asked this question, and it was like the first moment I actually answered it honestly. So that speaks to so much that was kind of sheltered in my home. But I grew up with an awareness there was a lot of untreated mental illness and addiction in my house, and we were an immigrant family and newly immigrated, and it was a lot of chaos in the midst of a lot of really wonderful resourcefulness. And I think I kind of just wondered, what were certain things that I had access to that other kiddos who might have had a similar experience didn't, and what did that mean? So I always wanted to be someone who thought about helping folks. And helping families that look like mine, and so it kind of has been my North Star. Could I have imagined it would have resulted in all the things I've done? I don't think so, but it's always remembering my why, and also it feels very ancestral for me to do this work because a
Ancestral.
lot of my elders and family just couldn't get help, and it was important that they could.
Wow. Yeah, that's so important. But ancestral, how do you think your cultural upbringing informs your work?
In some ways, I think it's around, the legacy of silencing is a huge part of immigrant experiences in terms of what you need to do to survive. And mental health, historically, just being stigmatized, even if you're not someone who's of color or an immigrant, has really permeated in that way. So, folks being afraid to talk to their doctors. I come from a family where you wouldn't even go to your primary care doctor unless you were kind of bleeding out on the street,
Mm,
so even the prevention of that. And a lot of that had to do with, believing that if you were sick or you were ill, if people find out, you weren't seen as worthy of employment or being able to provide for your family
mm,
anymore. So I think those kinds of things have helped shape too, also sort of the beauty of my culture in terms of belief in community and belief in um, supportive healing structures. And what does it mean to actually just sit down and talk to someone? What does it mean? The phrase "it takes a village," like the whole village can come together to take care of someone. So I think there's both sides of those make it really beautifully complex, but super informative in terms of what I do.
yeah, wonderful. So what are some of the challenges that you witness and have witnessed over time that really get to you that you want to help solve?
Yeah. Um, so there's two ways to kind of answer this. So I'm a clinical social worker. Then I'm an epidemiologist, and so for me, I'm really interested in looking at the micro experience of you and I maybe talking from therapist to client, and then how does the policies at play impact the way that could go well or not go well. And it started becoming really apparent to me early on that certain policies have made it very hard or very easy for people to have access to mental health care. And it's interesting because I think in social work and in other disciplines where we're direct patient providers, like data is not really a sexy thing to talk about.
Yeah, right.
No one wants to sit and look at numbers and collect them and analyze them. And yet, evidence is what generates the case and what we can do to implement a policy or a protocol or even a diagnostic intervention that could actually help somebody. And so when I went to social work school, I didn't intend to actually go to social work school, I should say that. I
Mm,
intended to just study public health and then took an interest in social work and clinical social work, particularly because of those two connections, right? Like, how does the macro really influence the micro and vice versa? And pretty immediately started seeing a lot of fractures in the system.
mm,
Who are folks that an emergency room or primary care doctor would use a phrase which I hate, but I'll say it here, like a high utilizer or a frequent flyer. Why
mhm,
do we
mhm.
deem somebody like that, right? That they keep showing up in an ER or in an office with illness and they just don't get better. And so the questions then started becoming there's a systemic issue. happening over and over and over again, where people aren't talking to each other. And, I'll call in medicine, psychiatry still fights for their place in terms of
Mm.
the fact that in the psych world, we treat invisible symptoms. You can't actually say, well, I know your arm is broken in these places. And so this exact thing will put it back together and make you be able to use your arm again. We don't really know the cause of a lot of mental illness. It's very hard for us to study that. There hasn't been a lot of efforts in understanding, even from the position of an MRI, like why does someone have bipolar disorder versus schizophrenia or something else. The dialogue has to be continuous between every facet of the care continuum. And the care continuum for me is more than just a treatment continuum. It is from the micro patient level provider all the way to the policy on the hill that impacts whether or not that can go well.
Okay, so you've made an effort to address kind of that whole continuum,
Yes, ma'am.
which is kind of ambitious.
Yeah.
So what have you learned about trying to address everything from micro and macro and some key takeaways about what can be improved?
Yeah. I think at a very concrete level, people need to have dialogue more with folks that aren't exactly in their specialty. What piqued my interest about what TNT does is because most folks I've seen have not been referred to me from their psychiatrist. Most folks are actually going to their primary care doctor, their OBGYN, or they ended up in the emergency room and someone said, I think you might be struggling with anxiety or depression. You should go talk to someone. And that speaks to the stigma, like at a community level, we still have, of like, what does it mean for me to go seek help or recognize something's going on? So I think at the very basic level, we have to start talking to people outside of our comfort zone.
Mm.
Like what does it mean for me to speak to physicians just as much as I speak to researchers or speak to policy folks? And, I pride myself on being able to convene individuals who don't normally speak together. So, an example would be um, I was previously the executive director of the Kennedy Satcher Center for Mental Health Equity at Morehouse School of Medicine. Really lucky to work with giants like Patrick Kennedy and David Satcher, who kind of taught me this skill, which is like convening can work, but it works better actually when people disagree. And
Oh,
so,
that's
yeah, so
interesting.
we would have, various convening mechanisms, even in COVID, where we would bring people together who wouldn't normally talk to each other. For example, we looked at the intersection between the criminal legal system and mental illness, which happens a lot. A lot of folks, their first entry into care is actually behind bars. And then they exit, and all of a sudden it's like, I have a diagnosis I didn't know I had. Some people go to prison and end up with a diagnosis because of what happens in prison. And it was really fascinating and amazing to watch police chiefs and abolitionists and advocates and people who are formerly incarcerated and psychiatrists all talk in the same place, right? And all of a sudden, kind of realize they're actually all aiming to do the same thing. But
Hmm.
you don't realize that unless you talk to somebody about it. So
Yeah.
it's a very kind of basic way to explain to people. Innovation is actually very easy
Huh.
if you go out of your comfort zone just a little bit.
Oh, that's so interesting. I love that perspective because it's very mind opening, and we're so afraid sometimes,
Yeah.
maybe not you, but sometimes to upset people, right?
Yeah.
So if we're going to disagree too much, we're going to upset people, maybe we're not going to get anywhere. But it sounds like it's in that intersection where innovation can occur.
Well, to your point, I certainly don't I don't want to feel like I'm upsetting people
Yeah.
either, but I do come, from a lens of having been a therapist. And still a therapist. It's really hard to seek help. That first moment, the first time you actually talk to anybody about what's going on with you, whether that's from a psychology perspective or even just medical care, it's really scary. And so I think what's helped me is that we all have fear. Fear is a primary emotion, just like all the other ones are. Most people don't want to go out of their comfort zone because it's scary. You don't know what you're walking into, you don't know what territory you're in.
Ah, yeah.
So, the creation of safety looks like lots of different things for different people, right? How does it feel comfortable for you and I to sit here and have a dialogue? It's about our body language, it's about how we talk to each other, it's about the things we do to make each other feel safe. I think when you're in training, you don't necessarily think about that. When we talk about a bedside manner, it's more about the nuances that happen between people. If I come in with the assumption that you might be a little nervous to talk to me just as much as I am to talk to you, it makes it easier for me to sort of say, okay, I can have more compassion, even this person's a little scared. And we do a lot of things when we feel scared. Some of them are not great.
That's true because we're in a fight or flight
Totally.
position, yeah. So I do know that with TNT, one of the things they're training their physicians in is motivational interviewing
Mhm.
because they know that they're not even going to get the information that they need to assist someone if they don't even know what's going on. So they are working on how do we speak to folks to provide that safety, which is really great. It's one of those things that people continue to talk about. We like the motivational interviewing training and all of that good stuff.
Yeah.
So, what are your thoughts on, TNT does have this aspect of expanding the workforce through empowering physicians with psychiatry skills,
Mhm.
but that, and what are some other ways too do you see of expanding access for folks that are not easily able to access care?
Yeah. I think one, it starts with where you're trained. And I commend a lot of primary medical programs that include perspectives at the professor level of people who are in other disciplines. Like, what does it mean to have a course taught to you by a nurse, have a course taught to you by a social worker, have a course taught to you by even a peer specialist, right? So, because you're immediately understanding that this is interdisciplinary. We all have to speak to each other.
Mm,
And it's not surprising to me that a lot of primary care doctors who can attach to that idea start to do things like embed those disciplines into their primary care practices,
interesting.
right? It's like put a social worker in your office, put a psych nurse in your office who may be on call or a consultation, but it's much easier than when someone comes in and you recognize, I think they might be dealing with depression, not entirely my specialty, but I have someone right here who can talk to you. We have the largest healthcare workforce shortage in history right now, which is something just to say. It is increasingly expensive to become both a doctor or any of the other disciplines, but also, the challenges with being able to get paid the way that you need to at the community level,
Mhm,
make it very hard for people to stay in the field. So I just
mm,
want to call that in is that especially COVID exposed so many cracks in the system that were already there. And it was like as soon as we had this pandemic experience, it flooded. I mean, it just like broke, right? So if we don't take care of our workforce, if we don't take care of people's needs, we don't start seeing like it has to be a team environment. You can't just be one person who fixes a problem. We will have repeat cycles of that. It'll be
mhm,
very hard. And so, how we're incentivizing people to work in places, part of the reason why I care about access and equity is I think about rural America and the number of hospitals that have closed in the last 10 years is at crisis levels and it's happening really rapidly.
wow.
And I believe the statistic is somewhere around over 200 million Americans currently live in what's HRSA designates a mental health shortage area. I think
Mm,
that statistic has gone up. The last time I looked at it, it was 150 million. I think it's even higher now, which means that there is not a single access point to a psych provider near you. No prescriber, no counselor, no therapist, anybody. So the role of primary care in those spaces becomes the catch all for everything, right? If you don't
mhm,
have
mhm,
access to someone to talk to, right? So, how do we take care of those folks? I live in a big city. We're very congested. We have a lot. And still, we don't have enough providers to meet the need
yeah,
of people.
yeah,
So imagine what it's like in rural New York, rural California, like those areas. So we have to start talking about that.
yeah,
I think people see issues of access at a level that they feel comfortable with because it's very overwhelming to think about how many fractures there are. But
yeah,
the other thing I want to say is like the dialogue between sectors is important. One of the reasons why I think people can retain themselves in both primary care and psych care is if their basic needs are met, like housing or food security or a clean place to sleep just at night.
mhm, yeah,
But in addition to that, clinic hours, right? So the 9 to 5 is very comfortable for me and you. It's not really comfortable for a lot of single parents or single caregivers who have multiple responsibilities, need to take care of so many people, and then they somehow in that window have to make their
yeah,
appointment.
yep,
Right, so let's add another layer. What if
mhm,
somebody has a child welfare case attached to them, right? They have had some penalty given to them somehow, and that mom then is mandatory, has to take that kiddo to therapy and has to go to therapy. If your clinic closes in 9 to 5, you're penalized by the system for not making those
Yes.
appointments,
Yeah.
right? So innovation is simple. Keep your clinic open longer. Incentivize people to receive a little bit of a higher rate if they're willing to work till 9, you know?
Mhm.
Um, I'll share that when I was first entering the social work field, I worked at a community clinic in Washington Heights, Manhattan. That clinic, I think, is the largest patient provider of bilingual services in the city, Spanish and English. And my caseload was huge. And I had to work 3 nights a week till 10 o'clock. It
Oh.
was very bad for my dating life in in my 20s. Like terrible. But what I learned is that the person who showed up the most was Friday at 9 p.m. I mean, every
Huh.
week she would bring her kid at Friday at 9 p.m. because she was so committed to her kid being well. But she had not had uh, access to somebody who was willing to see her in that way. And that case in particular, I'll just say another detail was the kid was struggling with social issues because he was entering puberty and going through certain things at night that can be really embarrassing.
Yeah.
And they had a studio apartment that they were living in with him, his two parents, and his sister who had severe special needs. And so, what I asked the clinic for was, do we have $50 to get him a mattress so he's not in the same bed as his family?
Yeah.
And as soon as he started sleeping,
Yeah.
coming out of his shell, talking to people, making friends at school, being bullied less, participating more, because if he couldn't sleep comfortably, he wasn't able to be himself. So I think basic needs are hugely part of the process and so ignored, right? We don't need some complex solution to that.
Yeah, I love that. And this is I've never heard that, like a therapist being like, "Okay, well, if we just buy a $50 mattress, we can solve this problem."
Yeah.
I don't think most people think like that.
Sadly, I don't think people think like that. No. And truthfully, it's because, again, our training programs have not evolved to include the experience of psychosocial stressors as a huge part of how people can be medically well or unwell,
Yeah.
right? So if we socialize training people, how do you ask that question, right? So
Mhm.
I asked, I was like, to tell me about what it's like to be 13 and a boy. Have you
Mhm.
thought about who you're attracted to? Have you thought about how your body's feeling? What is that like for you? Are you sleeping okay at night? As soon as I started asking that, I mean, it was impossible to get him to speak, but he said, well, my sleep's pretty bad.
Mhm.
I'm actually not sleeping. Oh, tell
Oh.
me more about why. What's your sleep setup like? What is that
Yeah.
like?
Uh-huh.
That is an assessment question that gets overlooked a lot.
Yeah, yeah, and you gotta be a little creative too,
Hmm.
I'm sure, to kind of dig in there and figure like, be a little detective
Yeah,
too, especially.
sniff it in the air maybe, but it's also finding particular things that you can connect with that individual. My first year of social work school at my placement, I had a supervisor and a mentor, and he would teach us, he self-disclosed that he was Puerto Rican, that he was gay, and that he had Parkinson's, so he had
Oh,
tremors, so he was an
mhm.
elder. And so he said, at my appearance, there's things that you can probably think about me immediately. And so anytime a patient meets you for the first time, whether they're a kid or an adult, they're going to see something about you that either makes them feel really good or really bad about themselves
Huh,
because your positionality based on what you present like is an immediate disclosure to them. And so
interesting.
to have an awareness of that is really important. It's like every
Yeah.
time I meet someone new, I have to know they're going to see my name, they're going to see my appearance, they're going to see how I dress, they're going to see all of that. So if I don't create a kind and friendly environment for that individual, I'm not acknowledging that they may be scared. They may feel fearful. I may be the first Indian person they've ever met. That's a
Mm,
real thing.
mhm.
Those are not taught in our programs. Like across the
Interesting.
disciplines, they're not
Huh.
discussed in our programs.
Wow, yeah, that's so important. So, what is the cost of not addressing the shortage? Like, what happens to people when they don't get the care that they need?
When they don't get the care, if we do, I
If
mean,
we don't
it's,
address the crisis, like
yeah.
what are the consequences of not
Well, I
solving
think
it?
we have to really ask ourselves, what is the cost of human life? I think in the earlier discussion today at the conference, there was an important dialogue on what does it mean to do effective suicide risk assessment? Like, how do you ask someone if they're feeling at risk of harming themselves? That question is generally very scary to providers to ask. So, if somebody keeps thinking that they're reaching out for help, they go to their primary care doc, okay, They didn't figure it out that I'm feeling really bad inside. Let's say maybe they talked to a nurse in an ER. That person didn't realize that I'm feeling really bad. They talked to a social worker. That person also didn't realize that's all these months that are passing with touch points that that person's not actually having someone go, I think you're not okay. Do you need something? How can I
Mhm.
help you? Right.
Mhm.
Um, so the comfort of asking that question means that you're responsible for the individual. We have a liability to think about. And I think that is a double edged thing because I have to think about my license. I'm responsible for your life, right? So the cost is there. I will highlight the economic costs too, which there was a report I was lucky to be a part of that we did at Morehouse School of Medicine looking at the economic burden of mental health inequities, right? So if we made our mental health care system more accessible to people, stratified by race and ethnicity, it was over $200 billion we could save if we
Mm.
just did that. And we just looked at public data sets. Like, how much does it cost someone's life if they are depressed and can't go to work? Right? We calculated it. And we started adding all of those numbers up.
Mm.
But that
Wow.
number doesn't include very critical populations because we don't do the research on these populations. So, active military, nursing homes, youth, people who are unhoused, and people who are incarcerated. And if you look at the rates of those five categories of people who have psychiatric conditions, they are the highest levels.
Oh.
So that number is a very short sighted estimation of exactly economically how much it would cost if we made our system more accessible to everybody.
Mhm. So where do you think some of the key differences can be made?
Um, I would answer that in a few ways. I think one, we need to incentivize people to work in areas that aren't the most glamorous location to work,
Mm.
and incentivize people to go to school to become trained in another language, right? And by incentivize, I mean actual literally higher rates of reimbursement that someone can receive. Let's say if they work an evening hour and they see patients, if they work in a rural area. And I think the role of university programs is really important to that because they're training grounds, right? Can you create a workforce that has a readiness to go into those places because you're creating internship or training or fellowship opportunities that they can already attach to the need for?
Yeah.
One of the biggest reasons why we don't have a lot of community psychiatrists is because they're not paid at the same rate that they are if they were a hospital psychiatrist or a private practice psychiatrist.
Mm.
And you walk out of grad school and you have hundreds of thousands of student loan debt. I wouldn't want to do that either, right? That
Yeah.
it's really hard. So we have to incentivize people to want to do that. And what is frustrating because upfront it probably costs more. In the long run, it's actually going to save us so much more money. And that's always been the issue with prevention is that
Yeah.
you have to invest upfront to be able to have the long-term impact, which your return on your investment is almost 100% always there.
Mhm.
Um, the other thing I would say is a note from the HIV crisis in the early 90s, right? So we had an epidemic and it was a highly stigmatized, marginalized population that was primarily being impacted by it. But then we realized that other people were also being impacted by it. And then huge communities were being impacted by it. And so how do we socialize it? So people started taking the clinical environment out of the clinic, started
Mm.
making it mobile, started making
Yeah.
it embedded into barbershops and
Mhm.
salons and grocery stores. You could go get pamphlets about how do you keep yourself safe. It was much less stigmatizing for someone to just pick up the pamphlet while they pick up their oranges and then go home and then learn how they could take care of themselves.
Mhm.
And I do think mobile care is something for us to consider because it's actually very cost efficient. It takes the service to the patient, meets them exactly where they are, quite
Exactly where they
literally,
are. Yeah.
and provides a service in that moment that they can probably rely on that much more. You know, mobile care has worked in countries all over the world. For some reason, the United States is not attached to it that much
Yeah.
until it comes to crisis. We have mobile crisis here. We don't actually have
That's
preventative mobile
true.
units. We
Yeah.
don't have maintenance mobile units that kind of go around and check on
Yeah.
folks.
And you've done some work with mobile
Yes.
units, and they're effective, sounds like.
Yeah. Would you like me to talk about it a
Yeah,
little bit?
a little bit. Yeah, just a
Yeah.
little.
So I was director of the assertive community treatment team in Manhattan. ACT is the most intense outpatient treatment you can receive in the community outside of a hospital. So, what it means is a team of anywhere between 11 to 14 interdisciplinary people, anywhere ranging from a nurse practitioner or an MD to a peer specialist, and a whole team of social workers that are in there. And it's wraparound care for folks
Wow.
experiencing acute mental health crisis. It is an end all solution. So these are people who are referred by a Department of Health who have been deemed like a high utilizer or someone who's in the emergency room a lot. And a certain number of those visits triggers a referral to an ACT team. So I was the director of an ACT team and unknowingly became the, because we didn't know COVID was happening, the director of the SAC team during the peak of COVID in New York, which was a transformative time. I think my North Star became much bigger coming out of
Mm.
that. And for perspective of people who didn't know this about the epicenter of New York City, was that because it's so congested and there's so many people there, the number of beds that were needed for folks who were ill superseded the amount of beds that we had. One of the first places where we cut hospital beds was in psych services. They were cut to about a quarter. So if one of my patients who I would meet in the community, and I've been present for medication administration in a McDonald's bathroom. If that's where the person wanted
Wow.
it, you take it. But we'd also pick up people from prison who were being released with maybe schizophrenia, take them to their shelter. All of these systems became fractured and became closed. And people don't realize like carceral facilities had almost 100% positivity rates. The psych services were slashed, like I said, to a quarter. So there was nowhere for people to go to stabilize. Shelters had positivity rates of like upwards of 90 to 95%. So these were people who had literally nowhere to escape this illness. And so I think the saddest takeaway was the extreme amount of loss that we had to go through, and still find ways to help people, which I'll get to in a second. But the loss also wasn't just death, it was disappearance. Some people just disappeared. We don't know. Maybe they got on a bus, they went somewhere else, they just left.
Mm.
Was incarceration. Some people, because they were so decompensated, did and we couldn't get to them in time. They ended up incarcerated because they commit a crime that they regretted. And then the loss was also just in terms of who they were as humans. Some people just never really bounced back or recovered. But there were some policies that were great. And I think that that's again back to like what can we do that is concrete. So New York City had a housing voucher program for people who were unhoused, who were attached to a psych service. It was basically hotels that weren't obviously having any business, said, how do we make business? They cut a deal with the city. They were able to give these rooms to some folks so that they could quarantine, be well. And on the flip side, we saw some people bounce back in a way we'd never seen them bounce back before,
Mhm.
solely because they had a place to sleep and take a shower and some privacy.
Makes a lot of sense.
It's pretty, yeah, right? When you
Yeah.
when you speak about it
Yeah.
that way, it's like, okay, why don't we just do the thing? But it's for some reason feels systemically hard for us to be able to all agree with that.
Mm. Yeah. I mean, it sort of comes down to money too, right? It's
Hmm.
like people have to invest on the front end to see it play out well on the other side,
Yeah.
right? Or down the road.
Yep.
So talk a little bit about health equity, mental health equity.
Hmm.
Like who's not getting the care, who is getting the care, why is there a disparity between the two?
Yeah. Well, I will say, health equity often is seen as just racial inequities, right? Is this an experience of people of color or not people of color? And it is so much more layered than that. Right? So in social work, we call it being the person in the environment. So I'll just explain that framework is that it's like myself, and I have microspheres of influence right around me, and then I have mesospheres of influence right around me, and then I have the macro ones that are right around me. And how I identify feeds into all of what those experiences might be like for me. Going back to my mentor who said, whatever about you brings you up or brings you down, I think systemically those things are true. Right? So, what does it mean to not only be someone who's of color, but also be female, or of color and live in a rural area, or of color and be physically disabled and not have access to somewhere, be of the LGBTQ community? These are all layers of identities that, from a policy perspective, we've not been able to understand that when I win, everybody wins, right? So, what does that
Mhm.
mean? We have to invest equitably. Some people need more investment than others because they've historically been disenfranchised so much. So, in mental health, because the stigma of mental health in medicine still persists so much, the outcomes are that much deeper, right? Going back to my origin story, a lot of communities have been forced to be silenced because of survival. And we don't talk about this facet of our history enough, but I'll call in during the civil rights era. You had this very political environment of activism where people were fighting for their rights to be included, and be politically seen, right? Civil rights for everybody. But one of the tactics to counter that was to institutionalize folks and say, well, your pursuit of freedom is delusional. So there was
Mm.
an uptick of people who were brown and black who were institutionalized during that period. And there's a lot of qualitative bodies of work that have interviewed those folks around what their onset of post traumatic stress and psychosis actually looked like afterwards, because that experience in itself was so stigmatizing, right? So there is no surprise that there's such a link between like our carceral system and our psych system and who gets care and who doesn't. I'll say the same for women. Women institutions were generally created for women who were experiencing hysteria. That used to be the word, right? So, what does it mean to be an emotionally sensitive woman? And if you couldn't control your emotions, you needed to be taken to another place where you could be around other groups of women and understand what those are. Right. What we now know scientifically is that the menstrual cycle is an acutely difficult experience for women to go through every month, right? And our hormones impact lots of those things, including pregnancy. What
Yeah.
does it mean to be pregnant? What does it mean to be postnatal? And that fluctuation in itself, the science is catching up to it. But that's why equity, I think people need to understand, is it's about everyone, right? It
Mhm.
really is about everyone because
That's a
again,
good point. Yeah.
if you don't think about things like this, you're kind of missing the point. It's like, why are things so expensive? Because not everybody's getting the care that they need. But we haven't regarded mental health the same for everyone either.
Right. Yeah, that's for sure. So, to wrap this up, this has been awesome. So thankful for you to share all of these insights from your experience. But to wrap it up, I'd like to just hear about the last moment that you've had recently where you felt hopeful or felt like I'm doing something that matters and it's going to work.
Oh, uh, it's interesting you're asking that question in such a tense moment nationally. I'm going to bring it back to patient care. So I work predominantly with a population of folks in the realm of being an accessible provider who are LGBTQ or immigrant descended, who are survivors of domestic violence, sexual assault, or crime. I specialize in post traumatic stress disorder. And, I think the thing that always is endearing to me is when someone can start to trust themselves. So less
Mm-hmm.
about the provider and more about themselves. So I have a young person I'm working with who has really been through the worst of the worst in life. And for the first time last week, she actually said, like, I'm really excited to make friends. I'm really excited to apply to grad school. I never thought I would even live past a year from now. And it's really because you've decided to be a container for all of my feelings.
Oh,
And so I think those moments are what it's about, right? I
yeah.
think if anybody can say that they care about making a system better or more inclusive, if I can leave this planet having moved it an inch just with one person, I think I've done my job. So that's the last moment. Most recently, I think I can call it happened on Monday.
That
That
was pretty recent.
Yeah,
I love that.
that makes this stuff meaningful, and
Yeah.
it makes it part of why I do what I do. It's really easy to lose hope, especially when you work in an ER or primary care office or with a population of folks who just have a lot of needs. And I've been told I'm toxically positive.
Re
I don't know.
Alright. I don't know, I
I don't
didn't get
know.
that, I haven't gotten that,
I don't know,
but
but
we're
I think hope is always somewhere. You just have sometimes just need help to find it.
yeah, and how do you maintain your positivity?
I I don't I it's hard because I feel like I'm letting the powers be win if I
Hmm.
don't.
Ooh,
And
that's a good
and
one.
if I think about what again, if it's ancestral for me, if I think about what generations before me had to go through and how much they weren't allowed to have and how much they weren't allowed to do, it's my responsibility to be different in that way, right? And I think when people feel in crisis or feel scared, our impulse is to segregate, it's to isolate and it's to segregate and to go be with the things that you know. And so if I don't remain curious, I call it being culturally curious. All the other phrases
Mm.
people use really bother me because I don't know what it's like to be you. I don't know, So if I can remain curious about people, that's what helps me stay hopeful. I
Oh,
can always learn something from someone else, and that keeps my ego in check too. Whatever
yeah.
platform anyone has or career people have doesn't really matter. If I can't talk to you and you can't talk to me and we can't find some sort of way to relate to each other, we all have something we relate to each other as being
Yeah,
humans on
for
this planet.
sure. I love that phrase, culturally curious. I've never heard that, but I'm definitely gonna use it.
I mean, and honestly, it's like we're not allowed to use a lot of words right now because of what's going on in the world. And I'm still getting asked the same questions you are. And, that's always been something I've leaned on is all I care about is getting to know somebody so
Yeah,
that I can understand how I can help them. But there's no way I could tell someone that I understand their experience 100%.
yeah,
So to be culturally competent, how could I be competent in your experience? You're
yeah,
the expert. That's your
yeah.
responsibility. So to be curious about you, I mean, it's to ask you, right?
That makes
What do you
sense.
like? What do you not like? How do you identify? What does that mean to you? Tell me how you pronounce your name. Such an easy thing I think anyone can do to make someone feel really included.
Yeah, and that's hopeful too, right? Because that's easy.
Yeah,
That doesn't mean you have to know everything about everyone and every situation. That just means that you can ask questions and be open and curious.
yeah,
So I love that.
absolutely.
Thank you for sharing.
You're welcome.
Well, thanks for joining us. Really appreciate you coming all the way from New York to talk with us and enjoy the rest of your whale watching later today.
I'm so excited to whale watch. It's going to be so great. Thank you for having me, and also thank you for giving visibility to issues in a time where I think people are getting really uncomfortable.
Mhm.
But for someone like myself, like I signed up for a license and I have a responsibility, and I think people need to just remember their why. Like, why do you care?
Yes.
Why do you care about having people feel better? I
Yeah.
care, as I shared here, because of my family. It's always about them. So I just hope people start to do that a little bit more.
Love it. Thank you so much.
Okay.